and get your advice. As pretty much all of you know, my retirement is set for July the 1st of next year. And so I have a year-ish left to move our next project forward. And Unorthodoc, the Unorthodoc that you all know and love isn't going anywhere, at least not yet, but we're opening another chapter. Many of you in this room have been with me and been with Unorthodoc for the last 11 years, and several of you have been here much longer than that. And you all took a chance on this strange idea called direct primary care, when most people thought it was crazy, or it was elitist, or it was bad. For my really long-standing patients, maybe you simply came because you trusted me, for which I am eternally grateful. Props. But I'm pretty sure that's not the reason you stayed, and I'm also really sure it's not the reason you're in this room today. Something's going on here more than me. Many of you, like me, are old enough to remember when healthcare felt more human, and when you knew your doctor, and when your doctor actually had the time to know you at least a little, and you saw the same doctor every time you showed up at the doctor's office. And over the years, I think that we've all watched something really important slip away and very quietly grieved it. But what's even sadder is the young people who are coming along who've never experienced what it's like to actually have a relationship with a doctor, or even sadder than that, the young doctors who are coming along who have no idea that that's how medicine can be practiced. Many have entered medicine knowing only a system that feels rushed, fragmented, and transactional. Many more have turned away from doing primary care or turned away from becoming doctors entirely because wise old farts like me told them it was not a career to get into, because it would eat you up, it would chew you up and spit you out. Thank goodness for direct primary care, or I would still be saying that.
Verification code from Doug.
I have spent the last 3 decades of my life trying to preserve relationship-based medicine inside the insurance system. And some of you guys who are my old timers remember when Carver Pediatrics and Internal Medicine felt a great deal like Unorthodoc does right now, because we pushed the limits of what we could do inside the insurance industry to create something that felt welcoming when you showed up. And God bless them, to this day they're still trying to do it. But year after year after year, the payments started dropping, appointments were getting shorter, paperwork was amassing, and decisions were being moved further and further away from you and me. Then one day, after years of trying to follow the rules as best we could, an insurance company, a large insurance company that shall remain nameless, asked us, not very politely, for tens of thousands of dollars back from our tiny practice. One day, one time, certified letter, $20,000 please, over billing technicalities that they couldn't clearly explain and for which we had no recourse. And that was the day I made a realization I couldn't ignore. I knew at that moment that I was going to feel safer putting my future, my mental, emotional, physical, and spiritual future, in the hands of patients I hadn't even met yet, rather than keeping them in the hands of the system I had spent my career trying to work inside. I realized that we were all safer when we were on the same side. And that realization became Unorthodoc. That idea was really actually very simple. What if doctors worked directly for their patients instead of the middlemen? What if we restored time for doctors to know the people who were sitting in front of them? What if access itself became the most important medical intervention we had to offer? That simple idea became the bedrock not only of Unorthodoc, but direct primary care in general. And over the last decade, what started as a tiny experiment has become a movement that grew from about 50 clinics when Unorthodoc started, 50 clinics nationwide, to over 3,000 at my last check. a movement. But the last 10 years for me have been a metamorphosis, because each day that has passed as I've worked inside this model, I have every single day felt less and less powerless, not just in the medical system, but in general. Agency really matters. But what's more important than my feeling less powerless is I've gotten the opportunity to watch all of you feel less powerless too.
That's right.
You started asking me more intricate and in-depth questions with greater nuance. You actually wanted answers to the things that were plaguing you or waking you up in the middle of the night. You started expecting more out of the system. You started advocating for yourselves more, whether it was in my office or everywhere else that you went. And when the system didn't respond, we got together and started finding ways around it together. We had felt trapped inside a system that was just too large to influence, but then something surprising happened. We stopped waiting for the system to fix it. We started helping each other instead. And that act changed more than healthcare alone. But there is a remaining problem, even as we've made healthcare simpler, more personal, more affordable. Something continued to bother me. There are still people, many people out there who couldn't afford to walk through our doors.
That's right.
We escaped, but not everybody could come with us. One of the hardest moments for me in primary care often isn't sitting with somebody through a difficult diagnosis. It's when somebody really needs help, and I realize that the system has already priced them out of getting their care early enough to be of value. I've had patients say, oh, if things get worse, I'll come back. And you know exactly what that means. They'll come back when it becomes dangerous, complicated, and way more expensive, because the system didn't make room for them sooner. So that is why the Unorthodoc Foundation Incorporated was born. I spent my career trying to solve this problem upstream. Before I retire, I finally see an avenue to solve this problem here. Not a charity clinic, not a forever grant-dependent project, but as a self-sustaining community clinic built on the same direct primary care model you guys already believe in. That's why the Unorthodoc Foundation was created. And now, for my visual learners, I want to show you something. Just give me a second. We all thought. Just a minute, I gotta celebrate this. I'm so happy to see that slide up there. We all thought that primary care was supposed to be the front door to healthcare, where problems were caught early and relationships help people stay healthy. But the insurance-driven system pushed doctors into rushed visits, endless paperwork, and fragmented care. In self-defense, in self-defense, both doctors and patients started abandoning primary care for good reasons. But a better model already existed, and for the last 10 years, more than 10 years, you and Unorthodoc chose direct primary care. We have monthly memberships, MDs work directly for patients, not for insurance, and longer visits, easier access, and earlier solutions, as well as more affordable care have been the result. And it's been proven in over 3,000 clinics nationwide. Our remaining problem is that affordable quality care is still out of reach for more people every day, and especially lately. People grow untreated until they become emergencies. There's a solution. We're calling it, for lack of a better term, a pay-it-forward solution or a pay-it-forward clinic, where the Unorthodoc Foundation, where UFI, I'll just call it that for short, UFI plans to make clinics on the pay-it-forward model, where community heroes called benefactors pay $200 a month, and half of that payment supports their care, and half supports another community member without access to care. That half is deductible, which is important to everybody in this room. Excuse me just a second. That's not a tech glitch, that's a person. That's a person in space glitch. The benefactor gets great care, the beneficiary gets great care. It's one patient helping another. One patient helping another. And something interesting happens when a clinic like this becomes healthy and stable. It starts reaching beyond its patients. It creates a space where doctors can continue or start practicing relationship-based medicine without burning out or becoming trapped in systems they don't believe in. The model more than restores access, it restores workforce. With those people willing to provide conscientious care, they have a place to work. But wait, there's more. 200 to 250 benefactor patients with an amount of money for their membership that's appropriate to the area where they live become the backbone of the clinic. All right. And it turns out that we only need part of that money to run one doctor and one patient care coordinator, roughly 65%. The surplus starts the next doctor clinic, either the next doctor or the next clinic, depending on the needs of the community. That means that our benefactors get great care, the beneficiaries get great care, doctors get great patients, and the community gets a great clinic. So that math basically goes this way. 1 + 1 = way more. What we're trying to build is bigger than a single clinic. The goal is to create a model that any community could adopt to reclaim right-sized health care for itself. Not because a corporation figured out how to make it profitable, not because the government mandated it, but because ordinary people chose to take care of one another again. In short, this starts with people. People willing to support each other and bring care back to their community. People tired of waiting for the cavalry to arrive from somewhere else. People ready for the antidote to powerlessness. And the beautiful part of this, we don't need anybody's permission to begin. Do you feel it?
Yeah.
We can actually do this. My notes say breathe. Okay. The remarkable thing for you, my current patients, is you're already the true believers. You're already doing exactly what we need benefactors to do in this community. Your $200 memberships protected enough time for me to write this next chapter, but in the future it could restore more than one person's faith in healthcare. Fuel a real person-led movement. We're going to be talking about funding before we go today, but today isn't so much a fundraising pitch as it is a strategy meeting. And the reason I've asked you here. However, before we talk about how to make this clinic successful, there's somebody really important I want you to meet if you haven't met her already. Why?
That's great. I love that one.
Thinking about retirement. The hardest question is not what I'm going to do next, or what color my hammock is going to be, or what beach I'm going to be lying on. It was who was going to lead Unorthodoc? Who was going to practice medicine the way it should be practiced? Who was going to not be me, but carry on the things that me wants to still be here? Yeah. I looked very carefully for someone who shared that philosophy, and lo and behold, she found me. Dr. Nayo, the first physician to lead a UFI clinic, came through the UNC Family Medicine Training Program, and which, by the way, is one of the 10 top training programs in the United States. But what impressed me even more than her training was the way she thought about patients. Thoughtful, curious, relationship-centered, the qualities that make this model work. And I'm incredibly excited for you to get to know her. Please join me in welcoming Dr. Amy Nayo.
Higher, 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 higher.
I may have to just take it off. Okay, there you go.
Can you guys hear me okay?
Yeah.
Of course.
Thank you.
She's got me all emotional. I haven't even started talking yet. I'm going to take my sweater off. First off, thank you everyone for being here. I know Saturdays are busy and everyone has lots of things to do in life, so we really appreciate you taking the time to brainstorm with us today. Dr. Annis and I have always been amazed by the diverse talents and perspectives of our patients, and have had the honor of individual moments in the exam room with all of you. But seeing you all here today as a group is incredibly inspiring. There's so much power in group actions. So again, thank you for being here. I think Dr. Annis did a beautiful job explaining the concept and what we're considering. So I'm not going to take a lot of your time. Instead, I would like to marvel for just a moment with you at how unexpected life can be. If there's one thing that I've learned in life, it's that we should never say never. Justin Bieber apparently wrote a whole song about this, but I promise that's not where I learned this. Truly, God seems to have a sense of humor about the word never. As an example, there have been many nevers in my life which I should not have uttered, but one was when I was in medical school. I had a good friend who was also in medical school with me at UNC, who was sure about what he wanted to do with his life. He wanted to go back to his hometown of Wilmington, North Carolina, and he wanted to open a direct primary care clinic. And this was in the early days when direct primary care was not a thing, and primary care was not very popular. And I said to him, and his name is Brian Lanier, by the way, if anyone has friends and family in Wilmington, make them go sign up at his direct primary care clinic. But I said to Brian, I would never do direct primary care. I had good reasons. So my reasoning at the time was twofold. I told Brian I wanted to focus 100% on doctoring, and I didn't want to be distracted by managing a business. I am, after all, a child of two academics, one is in the room here today, who really didn't teach me anything about being business-minded or entrepreneurial. Learned lots of other things from both of them. The second reason for saying never to direct primary care was that I came from an underserved background. My formative experience in young adulthood was serving in the Peace Corps in West Africa. I've worked in healthcare for the homeless clinics, refugee clinics, federally qualified health centers funded by the government for uninsured, and finally was a rural family doctor in North Carolina. I didn't become a doctor to make money and run a business. I became a doctor to take care of people. As you can see, God thought the idea of my never practicing direct primary care was hilarious. I've since learned that the ethical and just practice of medicine requires two parties investing in the ownership of primary care: physicians and their patients. Physicians must own the business of medicine as much as they own the art of medicine. Indeed, physicians relinquishing the reins of the business of medicine to third parties, whether they be hospitals, corporations, or now private equity, is the core of why our American health system is in such disarray. Don't get me wrong, I'm not saying physicians are expert entrepreneurs. No, I'm saying physicians are artisans who should care enough about their craft to maintain ownership and the autonomy to do what's right for our patients. And in this model, incentives align. When you, our patients, pay us directly, you hold us accountable for the quality of the care that we provide. And so clearly, I've come full circle since medical school. My first reason for saying never to direct primary care has long since fallen by the wayside. I've learned to manage the business of direct primary care. I know how to do QuickBooks, so I really know this. I say frequently, and without any humor, that direct primary care has truly saved my professional soul. I do not think I would be practicing as a physician if I hadn't found this model. I am fulfilled and blessed to do what I do at Unorthodoc. Which brings up a question. Why do I want to change anything right now? I have patients I love caring for, and I have a business model that works. I've been asking myself this question a lot over the first few weeks. I joke that one of the reasons why it's hard for physicians to be entrepreneurs is because we're incredibly conservative. We don't like risk. We want our patients and our ways of being in the world to be safe. Another mantra of mine is, if it ain't broke, don't fix it. Unorthodoc as we know it right now is most certainly not broken. But the world right now, well, the world feels pretty broken. And the US healthcare system is definitely broken. Broken for both patients and the physicians who practice medicine in this country. So now, more than ever, in this crazy world we live in, I think each and every one of us needs to push ourselves to care for our community. It is very easy right now to feel powerless and hopeless, but it's not true. There is power in community. We all have some combination of time, talent, and or treasure to offer our local communities. It is my time to prove that my second reason for saying never back in the day about direct primary care is unfounded. I want to show that direct primary care can, in fact, be a community-driven vehicle for taking care of the underserved. And amazingly, I think the model of care Dr. Annis is proposing takes me right back to my Peace Corps roots of empowering local communities to lift themselves up. So I'm leaning in, I'm saying yes to this, I'm acknowledging the irony of my prior nevers. I'm committed to sharing this better way with as many patients and physicians as possible. But I can't do it without you all. We can't do it without you all. So thank you for being here today to help us craft this next chapter of Unorthodoc. Woo!
Thank you, Dr. Niall. Oh, wait. All right. When pictures are taken of the two of us together, she often goes like this, so that it looks like we are close to the same height, and nobody ever believes it. And when we stand our full height, we look like Mutt and Jeff side by side. So, forward. So, let's move to the primary reason you all are here today. The goal is to figure out what is the most important about this model to you, and the best way to recruit benefactors, because as we've outlined, benefactors are the backbone of the way these clinics will work here and hopefully everywhere else. You are let's see, I originally said you were going to find reflection sheets at your tables, but your table hosts have them. So table hosts, will you pass out the reflection sheets now? And there are pens at your table. And if anybody needs any more sheets, just raise your hand. grab some, she's got some extras. Okay. All right, everybody got a reflection sheet and everybody got a pen, yes? All right, and I think you've all met your table hosts. Your table hosts at each table are there to help coordinate the discussions we're about to have and to keep the table on track so that we can finish on time. I don't want to take up any more of your Saturday than we already have. We're going to go for about 10 minutes first to look through the 4 questions on your reflection sheet, and then one at a time, really consider your answers, write them down, write on the back if you need to. And then after about 10 minutes, we're going to close that and start sharing. And share your answers, propose questions, learn from each other, write more if you're inspired to. We're going to remind everybody when the 10-minute mark, when we hit the 10-minute mark, and then again when we hit the 25-minute mark. And then we'll have some sharing with open mics. Most importantly, you are not required to share anything. Pass is a universal safe word in here. So anything you want to tell us, if you don't feel like sharing it, you can write down and hand back to your table host or directly to us, or you can tell us about it later on Spruce or when we meet in person. Let's see. Oh, that's it. Begin. Ding, ding, ding. What you just did matters more than you realize. You didn't just listen to an idea. You pressure tested it, you translated it, you considered how it might work and look in the real world. And now I'd like to hear a few reflections, anything that stood out for you or something that you want us to make sure we get right, and even something that maybe gives you pause about this whole idea. And remember, pass is the safe word for the room if you do not want to talk. And Jody is our mic runner.
Back here.
Yep. And maybe, I'm going to ask if any of the table hosts had something come up that they thought was particularly share-worthy. Okay, you got one right there? There's a hand.
I'll be the, pass off table host.
Gotcha. Hey, because our table host.
Thank you, Lori.
You're welcome. Hey, I'm Lori Carter. I'm the OG, right? We were at the previous practice and we've been here since day one. With our 19-year-old. One of the things that came up in our conversation.
Lori, hold on just a second. Just turn the mic up towards your mouth like you're
Even more?
There you go.
Holy
Perfect.
cow, I already feel like I'm loud as I'll get out, but
No,
I'll
it's
come
okay.
out. All right, so number 2, we aligned at our table that it's very important and we feel really good about being able to do something for others, basically through what we're already doing. And then the other question came up is the criteria, which is like a yes but or a yes and. Our table was interested in how we would choose the incoming patients.
The incoming beneficiary patients?
Correct.
That is an incredibly good question. Would you like to head the committee that's working on that?
I would not, but I think she would.
Okay.
But you know what I'm saying? Like
Right.
that piece.
Yes.
I mean, I personally, I'm sure everybody in this room can go, oh, and my neighbor, and my girlfriend,
I
and
am
my kid with a,
absolutely, I'm absolutely certain that everybody in here knows more than one person that would qualify for, or that they would love to host.
Yes.
And we're working on that. One of the things I do want to tell you is I don't want to get into such strict means testing that it feels like people are signing up for Medicaid.
Right.
Or not, or getting thrown off of Medicaid. So we have yet to determine what the exact criteria will be, because I want to be able to function on a trust-based system. And it may be that somebody has to suggest them. Yes?
Well, and I just wanted to add, I was talking to one of my favorite people who works at Weaver Street, and she was sharing that her mom is between whatever system is out here that's the paid system and Medicaid. Right? I think there, in addition to people who are at Medicaid level and below, there are also people who are right in the cusp.
Yeah.
Right? Who can't get the things that they need.
Right. No, exactly. And there are so many people who can't get what they need, and I know that we don't have the size to meet that yet. But that's my crazy dream, is that we shame the government into doing it right.
This government has no shame.
This one has no shame. I didn't say that in public.
I did. All of that.
But you didn't say that on the microphone, though.
Yeah,
This
I
government
noticed.
has no shame.
yeah, right, okay.
Okay.
What would you like to say?
One thing that came out of our conversation was the idea of clear, transparent governance.
Hold your mic up a little bit.
Sorry.
Yeah, like you're gonna eat it.
I don't do that.
We can hear it fine.
Anyway.
I understand.
I know. Anyway, but having clear, transparent governance and bylaws so that people who are looking at the organization can be confident that it's well run, well managed, and the funds are being used the way they say it is. So that was one thing that came out of our conversation. I think the other thing is really helping people to understand the key difference between this model of care, which is very engaged and accessible, and the typical model of care that everybody is getting so frustrated with.
Yeah.
I think most people nowadays are really struggling with feeling like the system cares about them at all, because it doesn't, frankly. And being able to offer something where if you can help, that's great. If you can't, there's still an opportunity to get that kind of care, that access. And then as a benefactor, like one of the patients that's supporting someone else, knowing that, frankly, I don't necessarily have to change my engagement with Unorthodoc, and I'm still going to be able to help somebody else, is really attractive.
Yes, thank you. Thank you. I forgot to mention that probably the way the model will work for beneficiaries is that everybody's going to be expected to have some kind of investment in their care. And the beneficiaries may be paying $50 or $10 or $5, but because direct primary care has demonstrated over and over again all over the country that people engage in their care differently when they invest in their care, when it becomes an investment of theirs.
That's right.
And it doesn't really matter what the amount of money is. There are plenty of models. There are actually people who are trying to do this in smaller places all over the country, where it just doesn't matter what it is. It just needs to be something, and people's relationship to the whole model and the clinic and the people in it changes. And so I always think of health as an investment, and and a symbolic investment of where your money goes makes sense to me. Anybody else? Okay, there you go.
So, one of the things
Put it up
that,
in front of you.
oh, I know, right here. One of the things that came up at our table was the idea of trust. We sort of trust in this model, we trust you as our doctor. And bringing a slightly different, I'm in the phase of life where I have young children, big family, and I am like shouting it from the rooftops to other families that direct primary care is the perfect thing for a super busy family, because all of your care is in one place. You take care of my husband, you take care of me, all of our kids. I think I'm gonna be seeing you in the office like 3 times this summer for well checks for everyone, which we're actually able to keep up because it's made easy for me. Similarly, we're in a place where we can want to give back to our community, and by being a benefactor, it also makes it easy for us to do that. And so I think that sort of highlighting that it's additionally it's an easy thing to add. I think that one of the things that's important or thinking about going forward, I mean, in the phase of life, thinking about families is how does this model, how will we be able to sort of reach out not just to people who are on their own looking for their own health care, but I mean, having this model has really saved us, and as both health-wise, honestly, financially as well, but it's a really important model, I think, for families, and how can you help show that it's not just like, oh, this is just another, expense or another thing that I have to go out and find, but really keeping some aspect of it focused for families who I think could really benefit. And then you have, like this people throughout their whole life. Like my children, my son Elliot is 11 years old, and he was one of the first babies that he saw. And this is all the healthcare that my children know. They only know having one doctor, or a few days because we get sick, we kind of see everyone. Having one doctor who cares about them, who knows about them, who's seen them from babyhood. Now some of them are going through puberty and they're having all kinds of things. They feel so comfortable. As they grow up and become adults, this is going to be the model that they expect and want to give back to as well. So I think that focusing on not just the, yes, there are people of all walks of life who could use this, but and focus on families and getting sort of young believers in the model as well.
Yeah. I really appreciate you saying something about that. I really haven't thought about what I said earlier about young people who don't know anything about this kind of care. It's like, well, these young people do. They're going to be really stunned if they have to deal with this. They're going to be mad. So mad.
And that's what we've been doing for 10 years, isn't it?
Yeah.
Educating everybody.
Mm-hmm.
All of you had to learn what unorthodoc was in the beginning, too. You didn't know how it worked.
Yeah.
Right?
And
And
going
that's what we've been
forward,
doing,
in terms of enlarging this, that is a real challenge, because once we're outside of the walls of Unorthodoc or other people who have direct primary care, we're going to be teaching people both about direct primary care and about the community aspect of this. So it's going to be an uphill climb, but more people know about direct primary. Way more people know about direct primary care today than they did when you all started. Gosh, you guys took such a leap of faith. Hardy, go ahead.
Thank you. So I don't think I have anything profound to say. I think what's been said.
Lift your microphone.
Eat the mic, Hardy.
There you go.
I think that what's been said already is good, but I guess I just want to maybe drive this home. I'm probably going to be the last person, but where we kept coming back to at our table was how fortunate we feel, how much we think that this is such a good service, and how much we have benefited from it individually. And then I'll add my personal color to it. We want to be able to share it with other people. And there's really one difference between most of us and a lot of the people who are going to take advantage of this. And it's that we're part of the haves and they're part of the have-nots. And that's the only difference. And there's no reason that they don't deserve to have the access to the same things that we do. So all that just to say, this is fantastic. I think we're all on board. Let's go do it.
Yeah.
That's great.
Thank you. Thank you. I recognize that some of the patients who stayed with me, yes, I know I'm talking to people who are fortunate. I'm going to include myself in that. But not just folks. Just folks. Nobody in here is a billionaire. If you are, keep it. Well, no, don't keep it a secret. If you are, come and see me. I'll keep it a secret, I promise. But, people, I think that everybody in here is able to recognize there, but by the grace of God, go we. We're, one, a firing or, a shutdown, it's happened at the universities when, all the research grants disappeared. We've watched our community, a bunch of haves, fall apart. And it can be any one of us at any time. And it's I want the understanding in the clinic for beneficiaries that at any time they decide they're ready to become benefactors, the door swings in both directions. And I'm hoping that kind of safety and trust actually works that way, that people do change places from time to time and that they are able to call on one another. I'm serious about this not being a charity clinic. This is a community clinic and everybody's at different places in it. And I want as much as possible to put people on even footing. And yes, for the folks for whom this is not a big outlay of cash, God bless you. And I don't want to get into the system where I'm having to talk to, the heirs, of the Walmart heirs, you know, or Mark Cuban or whatever, to keep this going. I want you to be able to feel like you're caring for the people that live down the street or next door or in your families. Anyway, does anybody else want to pop a little share? Yes, Coralie? Oh, Mark and Coralie, okay. Let's do you two and then we'll go ahead and close.
So just real quickly, I want to say that for a lot of people who have participated in the healthcare system for some time, the health insurance system primarily, we're all used to paying for something we're not getting. Okay? And the beauty of this is knowing what we're paying for. And that is huge because you don't know where all the money goes. And also you don't have any membership, you don't have any belonging. You know, I paid enough into health insurance, into the healthcare system, that the money somewhere is already paid for me, for all of my care to be met for the rest of my life, because I've been lucky enough to be really healthy. You probably don't know that because we only talk when I'm not healthy. Okay, thanks. But the point is, here it's more tangible, and the opportunity to make it just viscerally clear is really powerful, and it's not going to be a new concept to people, because again, we all pay for things we don't get in the healthcare system.
I really appreciate that, thank you. That, the hardest question for me to answer when I started Unorthodoc is people would say, I'm already paying hundreds of thousands of dollars for my health insurance, why would I pay you more? Why would I pay more for a doctor? And I couldn't answer that question at first. And a year into it, I realized that just having access to me meant that people didn't show up in the emergency room, didn't show up at the urgent care, didn't pay for a stupid prescription they didn't need, or they weren't paying $500 when, if you know where to look, it only costs $50. You know, I ended up, if anyone who had a deductible, they ended up paying less at the end of their first year than they did the year before they met me. Amen. And that blew my mind. That math isn't supposed to work. You know, but it does, and it works every single year. And it's a hard thing to get across because we're so wound into this system. So Coralie, did you have something you wanted to say?
Yeah, I wanted to bring up what my table was talking about because they're all
They
gone.
abandoned us.
It seems that everyone had doctor appointments.
Not today.
Well, my mom has eye doctor. That's something. Anyway, we were talking on a more international level, and like people coming from other places who can't really access the systems, and for example, like language barriers. A lot of the systems that are built today are sort of designed to exclude those people. There's like a lot of instances of maybe people wanting to help but not being able to because the people on higher levels decide, oh, that's a loss of profit. So a system like this that's really designed on the community, on the people in it, is very helpful for those people as well.
Thank you. Thank you, yes. You know, we are lucky enough now to be graced with a fully bilingual position. Unorthodoc, well, can I say you're fully bilingual? 90%. 90%. Yeah. A little bit, right, you know.
Hey, don't forget, we got a French-speaking
Yes.
person.
We have a French-speaking doctor, yes. We have a Spanish-speaking doctor, and then there's just me who took a lot of French and doesn't remember any of it. I was very short-sighted in high school. I didn't learn to type either. How stupid was that? Yeah. Okay. Well, thank you. Thank you for sharing what's going on with you. I love the fact that you guys thought so deeply about this, and that you feel so deeply about this. So, what I heard when I was walking around the room is that this matters. What we're doing matters, and what you're telling us is that it matters. But it needs to work like this going on into the future for it to be meaningful to you. Me too. You know, it needs to keep working like this. And that's exactly why we started here with you guys. Honestly, the thing that restored my faith in my craft was no institution. It was the people who came looking for real help and real connection. that made this such a healing adventure for me. We essentially discovered and created this model together, and I hope you understand how vitally important that is to where we are right now. Okay, now we're going to talk about funding. Everybody is like, I know they're going to ask something. To make a clinic viable, we need 200 to 250 pledged benefactors. And I hope many of you are going to decide to become the first. We're asking benefactors, listen carefully, we're asking benefactors to commit to a full year, which is $2,400 up front, or to commit to 1 year of $200 a month. Not because we need the current cash flow, we're not even sure exactly when this is going to open. We actually aren't even asking you to pay right now. What we're doing is asking for, what we need is tangible commitment that capitalize on the most important currency in human interaction right now besides trust, which is social proof. When we go to doctors, patients, funders, communities, we need to be able to say this isn't theoretical, there's already a community that's chosen to build this. So, here we go, let's see, quick. Yes, right, okay, got the right one. When you guys came in today, we already had 10 pledges. So, that's freaking awesome. This would be a perfect day if I can add 20 more to that pledge group. And I'm looking to make sure that we have 50 pledges within the next 2 weeks. That's $120,000 of social proof, and that's something that funders will listen to, not because I want to build this on funders, but establishing a relationship with any number of really socially conscious groups, and being able to say, this is what we're doing, and this is who's willing to support it, makes people willing to consider giving us money. And when we have to, you guys saw that we were considering, maybe buying a clinic. When we have to do big capital expenditures, it helps if a funding group is willing to give us some money. But I don't expect that to be a large part of this. But I do expect social proof to be a large part of this, because you go out into your communities every day and demonstrate the social proof when you talk about direct primary care. And that's the single most important thing that we can cultivate. By the way, the first 250 benefactors for the first UFI clinic will have their names permanently displayed in our future clinic when we have it. You will be identified as the Unorthodoc Foundation Originals, or the UFOs for short. There we go. Our current slogan list, yes, is the UFOs have landed, or the UFOs are bent on world domination. And honestly, I'm not ruling out either one. So, in closing, let me see if I can get through this.
Sure you can.
In closing, at many points in this journey, this work has felt very vocational to me. It's less like a career. And it's been less like a career decision and more like something I've been called toward. My really long life has taught me to follow where that leads and to speak what feels true from that space when I get there. And today, what feels true for me is this. I can't trust the system to protect relational medicine because it can't be monetized. But I can trust the people who thrive inside of it. I can trust you. Thank you for coming today and helping us imagine an Unorthodox future.